So we will be discussing the ALK-resistant mutations that has become a very important part, especially when we have more and more choices to be made. These things have been discussed in previous, and there has been a huge unmet need in ALK-positive non-small cell lung cancers. ALK-positive non-small cell lung cancers usually affect a young generation. Treatment challenges, even with the availability of the second and third generation ALK TKIs, the ALK-resistant mechanisms, the CNS as a sanctuary site where there is an inadequate penetration, the durable control of the brain metastasis. So there is definitely nearly 40% of untreated ALK-positive patients do have a baseline CNS mets, and there is a need for additional ALK TKIs that can prevent the emergence of the resistant subclones in untreated population. And to confuse with us, we have this hugely crowded first slide where we have four options with us: the alectinib versus crizotinib. You could look at the hazard ratio of 0.43, nearly 57% reduced chances of progression. Brigatinib versus crizotinib, ELTA-1, again, hazard ratio of 0.44, meaning a 56% reduced chances. EXALT-3, insatinib versus crizotinib, again, hazard ratio of 0.5, 50% reduced chances. And then the lorlatinib versus the crizotinib, the CROWN study, nearly 73% reduced chances. And if it wasn't hard enough to choose the first agent based on the overall efficacy, overall survival, CNS activity, response rate, we have the challenges for the second-line treatment, because patients will ultimately develop resistance to the ALK TKIs due to the resistant mechanisms, which are around 53 to 71%. And among all resistant mutations, 29% will develop J1202R, which are difficult to treat mutations. CNS metastasis around 60%, with brain metastasis upon progression are associated with a poor prognosis. And what are the various mechanisms? Despite high efficacy, there are ALK amplifications, ALK mutations, activation of a bypass mechanisms, which includes the EGFR, HER2, MET, KIT, and the drug efflux pumps in the CNS systems. You could look at a beautiful diagram in Annals Oncology of how these mutations emerge. And out of various meta-analysis, I believe that's the gold standard. Lorlatinib has emerged as a first-line treatment in the first-line state. But what happens when you give lorlatinib upfront? Because we know when we give first-line upfront, the crizotinib, the resistant to second-generation TKI, is driven by these known mutations. And lorlatinib has a broad-spectrum activity against most known ALK-resistant mutations, including the G1202R. But there are certain mechanisms which are ALK-dependent as well as ALK-independent. So if you have given crizotinib upfront, there is an EGFR overexpression and IGFR1 activation as an ALK-independent mechanism. While you have given ceritinib, it's a c-MET gene amplifications, MEK and PIK3CA mutations. If you have given alectinib upfront, then there is c-MET gene amplifications and PIK3CA mutations. With lorlatinib, there is NF2 loss of function and mutations. And the second part is those mutations which you tend to develop. But what we have also seen is that the more ALK TKIs you give, the more PFS diminishes in the subsequent lines of the therapy. And therefore, when we put the higher generation TKIs upfront, more and more monster ALK-resistant mutations tends to appear down the lane of it. And you could look at the spectrum of crizotinib resistance, ceritinib resistance, alectinib resistance mutations that develop upon these with the same. So what happens when you give crizotinib upfront? Look at the three: ceritinib, alectinib, and brigatinib post-crizotinib. The response rates are around 56, 50, and 71%, with a median PFS of around 6 to 8 months, with 13 months with brigatinib. And the patients who have been previously treated with a more than one generation, second generation TKI, the overall response rate to lorlatinib, even after a prior second generation TKI, depends upon what mutations we are giving and where we are catching that mutations, whether we are catching them in the plasma or whether we are catching them in the tissue. And even though the duration of response and median PFS didn't differ significantly based on where we are catching. And if we give the first line alectinib, the second line ceritinib and brigatinib, the response rates are very dismal, around, let's say, 16% in 9 patients who have received ceritinib immediately after the alectinib, and 17% with brigatinib, with a median PFS of around 4 months. And after ceritinib, again, if we start giving alectinib, you could look at the response rates. Most of them are in PDs right now. And lorlatinib so far has a broad range anti-tumor activity against all the 5 known dreaded mutations of the most commonest. And therefore, it is important that the number of the ALK mutations may affect the efficacy of lorlatinib. This is the concluding slide that with rapidly evolving clinical evidence, I believe we have more and more to choose. So far, with looking at lorlatinib being the first runner in terms of the PFS and the OS. But then again, what after lorlatinib remains a question to it. So I conclude my slide and would love to answer any questions if there are any. Thank you.